Okay, welcome everybody to the first webinar of the HITH Society of Australasia. I'm Dr. Alexander Beath, one of the staff specialists with Royal North Shore. I'm joined here today with head of our vascular access team, our intensive care nurse practitioner and vascular access nurse practitioner, Elliot Williams. And then we also have joining us our transitional nurse practitioner, Liana Scott. Joining us today. And behind the camera is Heather Thompson, our clinical nurse educator, who is on tech support and who is running the chat. And if you have any questions today, if you can put the questions in the chat, if they're relevant to what we're talking about throughout the stage of the webinar, we'll answer them, or we'll answer them, look at answering them at the end of the questions. We've also put up a poll just to see, how each of you get your access in hospital in the home, in your hospital in the home service. Is it through a dedicated vascular access service like we have here in major metro Royal North Shore Hospital? Do you use radiology department, your anaesthetic colleagues? Be interesting to see how each of your services does that. I'm assuming everyone can hear us now. So yeah, over to you, Elliot. So I think in terms of vascular access is so important for us in hospital in the home. It's a big core business of what we do. It's so important. When it works well, it's great. We often have complications, so we need to know the ins and outs of every different form. And I think the way we're going to structure this webinar today is to start off with our most simple forms of vascular access, merging into our most complicated forms of vascular access. So I guess, Elliot, do you want to introduce yourself, your role, what you do in our service, how you work with hospital in the home, and then Liana as well, and then we can move into sort of our forms of cannulation.
Yeah, fabulous. So thanks for having me on. It's very nice to be here. So I suppose the way that our service works is that there's 4 nurse practitioners and some clinical nurse specialists, and we cover a range of functions. So we're intensive care nurse practitioners primarily, but one of the things that we do is we run our hospital's vascular access service. And so the nice thing is that means Monday to Friday in hours, there's a dedicated team to do a lot of the procedural work around whether it's putting in PICC lines, mid-lines, dialysis catheters, central lines, those sorts of things. But we also coordinate all of the vascular access for the hospital. So even procedures that we don't do, they're all booked centrally through us. And that just means that we have a really good sense, I suppose, of the volume of procedural work that's going through the hospital. And we often know of most of the patients that are getting devices in our health service. The other thing that we do is we do a lot of outreach sort of procedures. So we'll go and do ultrasound guided cannulas on the ward. We'll provide consultative services, especially to teams like you guys. So if there's a patient with a problem with their vascular access device, irrespective of if it's one that we've put in or not, so anyone on your service, we'll come and see them in clinic, and we can often troubleshoot devices that are having problems with whether it's patency or position. And so I think hopefully what that does is give you a little bit of capacity to be able to manage people in the clinic setting without having to refer patients into the emergency department if there's a problem that you guys can't fix yourselves. And so for us, we hope that what we're providing is a reasonably holistic service around vascular access for both patients who are in the hospital, but also our admitted patients in the hospital in the home service. And we kind of like to treat them as all part of the one, big sort of inpatient population.
And Liana, transitional nurse practitioner, soon to be endorsed nurse practitioner. Where do you see your role being particularly important in regards to vascular access in hospital and home?
So the vascular access team have been very supportive in the rollout of vascular access within hospital in the home. So obviously our challenge is the community side of things. So currently we bring most of our patients into the clinics to have their vascular access done, and they've very kindly trained me up in ultrasound guided cannulation, hopefully to further train in some other devices down the track once I'm endorsed. But we're just starting to roll out with portable ultrasound machine to try and get this ultrasound guided cannulation out into the community. So we're just in the early stages of that. But that'll just mean that some of our elderly or immobile patients can have vascular access, but out in the community without having to come into clinic.
I think that's, can I just say, I think that's one of the things that I have often found to be the most rewarding part of being involved with your service, even just in a consultative fashion, is you can see that having a coordinated approach to these sorts of things, which are, as you say, bread and butter, reduces things like people unnecessarily coming into clinics, let alone coming into ED. And I think wherever possible, you know, we kind of try and share that that philosophy with you. So I think I just wanted to highlight that for us, we've seen that that's clearly a benefit as well.
Perfect. And I think as a society, you know, I think we need to work closer to other societies like the Vascular Access Society, who will hopefully come and present at our conference at towards the end of this year, November. So I guess starting off on what this webinar is about, let's go to our most basic 101 access that, you know, everyone knows, everyone has access to, the peripheral IVC. You know, I guess, what are the different types of IVCs? How long can they stay in for? What kind of patients are we going to pull out our peripheral IVC for? Yeah, so what have we got here?
Yeah, so we've got a few things in front of us. The sort of standard cannula, whether you've got this specific cannula, which is a bit hard to see, but you've all seen cannulas before. The specific type of cannula is not quite so important in the conversation when you're just talking about one that's put in with a normal technique. It's more about picking the right patients. And so much of the conversation today will be around understanding where there's opportunities to use particular kinds of devices. I suspect most services are pretty comfortable with when to use a standard PIVC. The kinds of patients that you're probably putting these in are people who require short-term IV therapy, usually I would imagine antibiotics, and that I think importantly have straightforward vascular access. So they're not someone with extreme difficulty. They don't have problems where, you know, you're having to change the cannula every day. So people who you're fairly confident you'll be able to put the cannula in and they'll get a few days of therapy. I suppose the question about how long can you leave one of these in for comes up quite a bit, and there's a peripheral intravenous cannula clinical care standard from the Australian Safety and Quality Commission, and they've released that a few years ago now. I think it's 2021, 2022, and they also did a webinar for launching that, and there was a bit of debate even among the people who wrote the clinical care standard, because on the one hand, most services will have a framework where we say we put these in and we're pretty comfortable to say for 3 days, unless they are obviously going to stop working, in which case you'll know about them, for 3 days they're probably going to be no problems. So 3 days easily, but a lot of places now will say 3 days is the sort of standard, but if you've got another 2 days of therapy, or there's some pragmatic judgment to be made around saying that the cannula looks like it is clean, it's functional, you're not worried about side infection, then a lot of the times you'll know from experience here, it's possible to just leave them in for a little bit longer based on a clinical decision for that person. There are services that I know of that have a bit more of a systemised approach for leaving these type of standard cannulas in longer. And so there is a discussion kind of currently, even in some of the literature, just about these being able to be left in based on clinical indication. So I think the answer probably is that you should always balance this around saying, first of all, what's the intended duration of therapy? And obviously, what's the kind of infusate that you're going to put through it? So these are great for something that can be given peripherally, that you know will be for a short duration, and that if you think that it's going to require the patient's going to require a longer duration of parenteral therapy, then at that point you probably should be thinking about something different to start with. I think one of the interesting things for your patient population is the majority of them will be transitioning from an inpatient setting to a HITH inpatient setting, but there are increasingly, as I understand it, patients who are being referred directly to your HITH service. So it may be the case that sometimes you are starting them on therapy in their home using a peripheral IVC and then making arrangements for that sort of more definitive access device in the future. And I think the nice thing about that is that this is a really well understood and comfortable device that most HITH nurses and doctors will be, pretty fluent with inserting. So certainly not to be underrated. And I think something that, services will do well to continue to invest time and money in making sure it's available and done to a high standard. The other thing that I would just say about this is that, and I know that this is sometimes the case on your service, but you can put infusers on a normal peripheral cannula if it's a peripherally compatible solution and you're thinking about a very limited sort of duration of therapy. So pretty sort of versatile within those parameters, and sometimes means that patients don't ever end up needing to have a PICC line or a different type of line. So important that it's all part of the arsenal, if you like.
Yeah, so I mean, when we think of what therapy the patient will need, I think you also need to think, what device can we run that therapy through? So, 6 grams of kefazolin in an infuser, fine. 8 grams of flucloxacillin, then we need to be starting to think, no, we need more central access. I guess the other things, complications with something like that, obviously infection can happen with these. That's probably one of them,
Yeah, I think infections are, going to be a complication that's common across all of these as something to consider. And so good procedural asepsis, both at the time of insertion, but also and especially, in fact, during the care and maintenance phase. So I think one of the benefits that you get from having infusers connected is that you're not constantly re-accessing that device. And anytime you access or de-access a device, then you always run a risk of having an infection or an opportunity for infection to occur. But the other complications with these, and perhaps this is one of the drawbacks with your peripheral cannulas, is the risk of device failure, so malposition, and sometimes if you're going to be putting a peripheral cannula in and attaching an infuser and then seeing the patient get in 24 hours, one of the problems that you have is that unless the patient has noticed, and oftentimes my understanding is that's not necessarily going to be the case, you don't know that they haven't received whatever it is, half their dose of antibiotics until 24 hours later. So, making sure that it's in a good spot. So we're not probably trying to do this with the blue cannula, that's been put in at the base of the thumb or, in the back of the wrist. You want it to be in a good vein, probably on the forearm, definitely not in the antecubital fossa. Occasionally you can make this work in the dorsum of the hand, but I mean, for your patients, they're going to be at home. They're not in a healthcare setting where they can just easily, buzz for the nurse. Anyone else is on the end of a phone and then a car trip away, or they've got to come into clinic. So I think those considerations all need to come into it. If this is someone who doesn't have a good spot for a cannula and is going to be, difficult to get back into clinic, plus is, going to require infuser therapy, then maybe you would think we need something a bit more durable or less likely to fail. But for a lot of patients, it's a great starting point.
Perfect. And I guess we don't want to dwell too much on other things, but attachments.
Yeah, so actually, there's a couple of options. A lot of places will use extension sets, and the extension set, rather than just putting the valve straight onto the end, when it's done right, will allow you to reduce the amount of pistoning force that goes onto the catheter itself at the insertion site. So if you imagine that every time you're connecting or disconnecting where you've got just the hub directly on the cannula, any sort of movement is then, transposed down onto the, or transferred, down onto the catheter site, which causes a bit of inflammation. And then sometimes the only thing that happens is, one of the nurses will look at it and say the insertion site looks red and it's mechanical irritation, but that mechanical irritation also compromises the sort of insertion site to the point where you could get a bit of infection. So if you use an extension set like this, the benefit is you can tape it down in such a way that you isolate the valved component from this cannula itself. And it means that when you're pulling here, it's just pulling on the taped section as opposed to pulling on the cannula itself. The biggest drawback to this is your system needs to be aware of how to secure these down properly, because otherwise what happens is they're not taped and they're just a big appendage on the end. And then the problem is that you end up with, you know, an even higher risk of this pulling or being, you know, malpositioned. So these are great when everyone knows how to care for them over time and making sure that they're staying taped down in a loop. If that's not something that your system does, it's okay. It's not going to make the cannula sort of fail much more significantly, but there are some benefits to having these if you can. And they're reasonably affordable, and you get them so that they're, you know, not going to stop you from doing pressure injections in the CT scanner and all those sorts of things. So most of them are kind of fit for that.
Perfect. And then there's this one, isn't it? So that's obviously looks a bit longer. So, and I think this is really, you know, those referrals from the GP or from the spinal rehab physician, someone with, say, an extended spectrum bacterial lactomase infection in their bladder, they're going to need 7 to 10 days of ertapenem or treatment. I think that's when we're really starting to look towards this. Could you, do you want to talk about our longer ones? And can anyone put a 7-day cannula in? Do we need fancy ultrasounds?
Yeah. So we do talk about ultrasound guided cannulas being able to have a longer dwell time. There's kind of two reasons for that. The first reason is that, at least in our service, we apply a much higher degree of procedural asepsis to their insertion. So we have a procedure pack, which I won't kind of get out, but it's got all the right things in there. It's got, you know, ultrasound probe covers, a little sterile field, a drape that you can put over the arm, and, you know, a good stick to be able to clean everything. The important thing there, I suppose, is that you can apply the same degree of procedural asepsis to any cannula that you're putting in. The reason that we often say that ultrasound guided cannulas will have a more successful extended dwell is because they are usually going to be in larger veins that are slightly deeper. And where there's larger veins with a greater amount of blood flow, you're likely to get less sort of, you know, endothelial damage or activation from whatever the infuse aid is. You're less likely to get thrombophlebitis. And so you kind of have a potential that you're going to have a higher success rate. The other thing is you can be much more considered about where you put the cannula. So you stop being sort of restricted to visible surface veins only, and you start being able to find veins that are deeper, because even half a centimetre under the skin, you can't feel those usually. So you can start to find veins that are deeper and therefore not otherwise accessible using a typical kind of, you know, landmark-based approach or surface, you know, approach. And so I think to your question, can anyone put in a 7-day cannula? We say 7 days because here in our service, we typically say we're happy for them to stay in for 7 days and then we need to look at them after that. I mean, we look at them in our system all the time, but you need someone, either you know, a medical officer or a nurse practitioner or someone to say, yes, it still looks fine, the therapy continues to be indicated and we should use them. I think the answer to that is if you apply the same degree of procedural asepsis to you know, a standard cannula, then you may be able to leave that in for longer. And as I already said, a lot of our services that are like peer services will already leave cannulas in based on clinical indication. And certainly for ultrasound guided cannulas, there is a significant amount of services that will leave them in for longer than 7 days. We also are happy to leave ours in for longer than 7 days, but we don't leave them in indefinitely. We kind of, you know, are a little bit sort of one foot either side of the fence with that. And that's also just because whilst there's evidence around some of this, a lot of this also is based on how these sort of things are applied in your system. So it's great if all the nursing staff who are looking after patients with these devices are really good at care and maintenance. They're really good at picking up problems early. But if you're in a system like in our inpatient setting, there's a bit more variability there. We've applied some of those rules as kind of bumpers so that we don't kind of go ahead and create issues. But yeah, so I think these are great. These will help you if you can't find a spot to put a normal peripheral cannula in. They have all the same rules. Like, you know, you can't need to have 3 weeks of therapy and decide to put one of these in. Still needs to be peripheral. But the other really important thing is if you are putting them in with ultrasound, you absolutely must spend the time to find and ensure you have stock of these longer cannulas. And Liana, if you want to just show, so there's 2 long cannulas and 1 normal length cannula. So the 2 long cannulas are here, and the normal length cannula is here. So on the bottom of your screen, that's great. One of the big factors for success or failure with these is if you've got 50% or more, ideally 2/3 of catheter inside the vein. And so with ultrasound, you can be a little bit more controlled with that, but because you'll be going into a deeper vein and you'll be taking a sort of slightly different angle of attack, you really need to make sure you're picking a long enough cannula. If you put a normal size cannula in a deep vein, you might get it in to start with, and you might think, yeah, this is great, I can flush it, and I will almost guarantee you that there'll be a phone call in the next 4 hours that it's tissued. So, you know, these are the same price. These are a little bit more expensive, but, you know, essentially, there's lots of products on the market. There will be a longer version of the cannula you use in your service, and just talk to your rep or talk to your products people, and I'm sure you'll be able to get a hold of them.
Perfect. And then we're then going to soon move on to our, I guess, longest peripheral access. You know, between these two, do we have to worry more about thrombosis in the longer cannula in a deeper vein, or is that more for a discussion when we talk about midlines?
Yeah, I mean, I think the increased risk probably comes more with midlines, but certainly there's a thrombosis risk anytime you're going to place one of these catheters. The majority of the time, we're going to put these catheters into superficial veins. And so not that we kind of don't care if people get a thrombus, because it is an important complication to be aware of, and it's associated with device failure and all sorts of other problems. But the consequence of a superficial venous thrombus is obviously different than a deep vein thrombus. And one of the things that you'll find when we're talking about midlines particularly is that because we will put some of the midlines into the brachial veins, which are by their nature deep veins, the thinking about thrombus risk and catheter to vein ratio, which we'll talk about shortly, is a bit more important. I think with these, because we're generally keeping them in superficial veins, even though they're a bit, you know, deeper than skin level, still technically a superficial vein, the risk of thrombus is slightly less. There is obviously as well, though, an association with the amount of catheter that's in a vein and then the risk of thrombosis. So the more catheter in the vein, the greater there is risk of thrombus. But with ultrasound, you get to pick the biggest vein, and that's often the best one to put it in. It gives you the lowest risk.
And we've treated recently a few cases of superficial thrombophlebitis, and the therapeutic guidelines have fantastic guide on treating that complication. I guess moving on now to midlines. Before starting in hospital and the home, I'd never heard of midlines. It wasn't something that I'd learned during my junior years of being a doctor. Tell us about midlines. Well, you've got a few different ones here.
Yeah.
How long have you known about midlines? Been around forever? Have they been in the trauma setting only, or?
No, I think they have. Look, they've been around for a long time, but I think in Australia they're having their moment, you know, now and across the last few years. So midlines are essentially just a longer length type of catheter. Yeah, please take a longer length peripheral catheter, and they have the ability to have a longer duration as well. So this first one looks a bit more like a PICC line. So it's just essentially is a shortened PICC line, though it's actually, you know, manufactured and sold as a midline product. But then this other one, this other type here, is essentially like a really long cannula. So it's a 10 centimetre long 20 gauge catheter, but it is by, you know, for all intents and purposes, it's essentially a cannula, and we use this special device, which I'll show you all in a second, to put it in. The use case here really is around people who have peripherally compatible, infusion requirements that need them for up to 4 weeks. There are a few things, though, about midlines that mean that we don't necessarily suggest in our service that if you know you require 4 weeks of therapy, that you would use this line. So we'll get to some of that in a moment, but these lines can stay in for a maximum of 4 weeks. And they're relatively straightforward to insert. So for a HITH setting, understanding these two different types of midlines is really useful because for you guys, the use case is a little bit different, right?
Yeah, what kind of patients have you been using midlines for, Leon?
So for our patients that might be coming on for 2 weeks of treatment for an exacerbation of COPD or bronchiectasis, and our osteomyelitis patients that may be on up to 4 weeks of treatment, that's quite good for them. But the patients that are on infusers, we've found needing a certain device compared to the other one because we're having some issues. So Elliot will go through that with you.
So one of the nice things about the second device that you were showing, which is the more cannula style device, is it doesn't require the inserter to be in sterile gown. There's no loose wire or anything involved with the insertion. It's just all done with this device. So this essentially, which Liana can just hold up and show you, this is just like a really long cannula. Take the sheath off there and we'll have a look at it. So you can see that you've got a long needle with the catheter already preloaded along the top there. So the catheter is preloaded on. This is the bevel of the needle. And then essentially what happens is you insert this using ultrasound into the sort of basilic vein or cephalic vein or the brachial vein. So one of the upper arm veins in the same spot that you would put a PICC line. And then I just retract the wire for a second. As you get in to the vein, there's and just make sure people can sort of see your finger there. So there's this little push plate here. And as we're in the vein on ultrasound, we just insert this wire and then we thread the entire thing off, like a normal cannula. So you just got to push the wire all the way out first. Yeah, and then it'll go. And so it just comes off and inserts into the vein. So in this way, you can do this in someone's home. It's basically like a really long cannula. And you can then get up to 4 weeks of dwell time out of it. They come in various different sizes, so 20 gauge, 18 gauge, 22 gauge, and they come in either 10 centimetre length or 8 centimetre length. They're all pressure injectable, usually up to 5 or 6 mils a second. So patients we know, especially as they have evolving sort of requirements, even if they're on a hospital in the home service, they may need to come in and have medical imaging studies, in which case they've already got a device that could be able to have contrast pressure injected through it. And that's one of the kind of increasingly important features for clinicians these days about any of these devices that we choose, because medical imaging has such a sort of dominant role in how we manage and work patients up. So this is great because we can kind of put it in wherever you like, as in whatever setting, clinic, home, hospital. The drawback is that this is just like a cannula. So it can kink under the skin. And what we found when we first started, this was the first midline we started using here at Royal North Shore. And when we first started using this, we found that infusers would very regularly not fully empty, didn't we? And so we realised very quickly that they do have a tendency to kink. And so the use case for us tends to be intermittent infusions or intermittent doses of medication. So things like people who are on ceftriaxone or, as you said, ertapenem, they're all good examples of patients who we would say, yeah, this is okay. The other thing is that because midlines, they can last for 4 weeks, but there is a slightly higher risk of thrombosis with a midline, and we can talk about why that is in a moment. So I would usually feel comfortable with 2 to 3 weeks of predicted therapy, putting in a midline. But if we're 4 weeks, obviously or more, then I tend to think we should put a PICC line in, because I think the rate of device failure is just slightly higher than your PICC lines, and it's enough so that it's a bit annoying for patients to have another device resited. And so I would typically think you should try and put a PICC line in if you're going over that sort of 3 week mark. if you've got someone who's needing an infuser, this PICC style midline that you were shown before, which is just a shortened 4 French single lumen catheter, is really ideal because it's more durable. It doesn't really kink at the site. In the same way that PICC lines don't have that problem, this line doesn't have that problem. And we've had great success, I think, here using these for infusers for patients, haven't we?
Absolutely.
The difference with this around insertion, though, is that you do need to be in a sterile gown. You need to do a typical modified Seldinger technique where you do ultrasound needle, wire through the needle, take the needle out, and then put a dilator and sheath inserter over the top of it. So that is another sort of skill set on top of that. And it also means that you need the procedural space, certainly in our opinion, to do this in such a way that if you've got a wire, you're not going to sort of be so cramped that you're accidentally knocking it on things and then contaminating your field. Look, there are services that will put these in sort of settings that we wouldn't, so in smaller procedural rooms or like in more cramped quarters. I think wherever possible, you should just try and make sure that you have enough room to be comfortably in a sterile gown and gloves and put a bit of a drape over the patient and not be so worried that you're going to touch something, because of the functions of your surroundings. So it is really important. But it's also very straightforward to put in. So once you're proficient with ultrasound, this is a really easy line to put in. And the thing that makes a midline as opposed to this being a PICC line is that the tip doesn't sit in the central circulation. So that's the key feature with a midline. So the tip doesn't sit down at the cavo-atrial junction, and it shouldn't really pass the axillary fold. However, sometimes, depending on arm position, on X-ray, you'll see it protruding into the axillary vein, but it should be mostly confined to the peripheral circulation. So I think as far as midlines go, that's kind of the benefits. Some of the risks, though, and probably the number one risk, is thrombosis. So the reason that we tend to see a slightly higher thrombosis rate with midlines than PICC lines is because of the peripheral position of the tip, and that people have a tendency to like to sample blood out of midlines, which is okay, but the more you generate negative pressure on the tip, which is in a smaller vein and therefore far more likely to collapse under negative pressure, the greater the risk of endothelial damage and then the beginning of, thrombosis.
Circles, triangle.
Yeah. So I think, for us, part of what we generally advise when we put these in is, unless you really need to, try and avoid regular blood sampling from these. Not because they're not designed to be sampled from, they most certainly are, but you definitely increase the risk of thrombus if you're doing that very regularly.
Perfect. Thanks so much, Elliot. And I think just from the point of time, we should go to our this would be our most used device, I think, the PICC line.
Yeah.
So I was doing some reading last night. I learned a fair bit. I think there's a lot to learn with these devices. How do you insert these? In what conditions? Single lumen, double lumen, triple lumen. What's best? What should we be aiming for? Position.
So there's a bunch of evidence around this now. So firstly, the thing that guides a lot of our decision making in this tends to be the MAGIC guidelines, which are the Michigan appropriateness guidelines for intravenous catheters, and they're a great sort of consensus guideline which brings together a lot of the evidence at the time that they were written. And so we would typically put in a PICC line for someone who needed, as I said before, sort of around that 4-week of mark of therapy or more. And lots of services that you'll all be in will use PICC lines for really extended periods of time. And one of the great things about them is that they absolutely have an indefinite dwell time. So as long as they are indicated, functional, free of infection, free of thrombus, you can leave them in. And so certainly I've met patients who've had their PICC lines in, for instance, for 3 years, same PICC line, because they've had an ongoing requirement for them. Lots of places will put them in for cancer treatment. But the commonest use, I think, by far is for this sort of short to long-term antibiotic therapy in the ambulatory patient. So the way that we put these in is we do a thorough assessment of their venous anatomy. We use the ultrasound. We have a look at the upper part of the arm, and we use something called the zone insertion method. And so the zone insertion method really is just a way of putting a framework in place around thinking about the position on the arm where the PICC line should be coming out of. So problematic PICC line position will absolutely lead to device malfunction and reduced life, site infection, those sorts of problems. So the zone insertion method just describes using the upper half of the middle third of the arm to guide where you want the PICC line coming out of, because it's far enough away from this point of flexion and also far enough away from, you know, the axilla, which is full of bacteria, and another point of insertion of flexion, and really difficult to dress. So we don't want to see PICC lines that are going in the antecubital fossa. So that's where PICC lines all used to go in the antecubital fossa. There was no ultrasound. It was all just done with a cannula. And that was great before the advent of ultrasound, because it meant we started being able to use, you know, well, I say we, certainly I wasn't practicing when this was common, but the clinicians started to be able to use peripheral veins to place a central catheter, and that was sort of a bit revolutionary. We now understand that really what we want is for the PICC line to be coming out in the middle part of the upper arm, and we typically want to use a really big vein. So one of the things that we know is a problem with any of these, like we were just talking about, any of these devices, is thrombosis. And basically, the only really modifiable risk factor that we can influence is this thing called the catheter to vein ratio. So we never want the catheter to take up more than 40% of the area of the internal diameter of the vein. And so we'll actually, when we're doing our assessment with ultrasound, we'll find the spot that we'd like to use in the correct region of the arm, and we'll actually freeze the image and take a measurement of the diameter of the cross-section of the vessel. And so if we do that, and there's a study by some clever people from South Australia, I think the author is Rebecca Sharp as the primary author, where they did a randomised control trial looking at the different catheter to vein ratios and then, thrombosis rate. And they've published the exact numbers of, catheter size versus internal diameter of the veins. But when you do that systematically, you can ensure that you're always going to be putting in the right size catheter into a big enough vein. It also means that we then inform our sort of advice and decision making about referrals that come to us at every point right up until the moment of insertion. So if we looked and someone had no suitable veins in their arms, then we may change the decision and put something else in. So insertion is always done under really sort of strict procedural asepsis, full body draping. You've got, everyone in sterile gown and gloves, and it's always done with ultrasound. Local anaesthetic, and the whole procedure in sort of experienced hands takes about 5 or 10 minutes to actually do, but generally patients are in the procedure room for about half an hour. So it's pretty quick, and the way that we do it is with ultrasound, and then we use a dynamic tip positioning system, which is intracavitary ECG, where we basically just turn the PICC line into an ECG electrode, and we watch the amplitude of the P wave get bigger and bigger as it gets to the cavo-atrial junction, which is where you need the tip of the catheter to be.
So some hospital in the home services will need an X-ray before the patient comes onto their service. I mean, as a hospital in the home clinician, I don't mind that in some ways, because particularly if they're coming from out of area, and I get a call saying that the line used to be 25 centimetres, now it's 23 or 27 centimetres. It gives us a bit of a baseline. What's your opinion? Does everyone need a chest X-ray? Obviously, if it's within service and you've put it in, I'm happy with that. What's your opinion around that?
Yeah, so I think the most important thing is that the tip needs to be at the cavoatrial junction or in the lower third of the SVC to prevent the risk of thrombus. So if there's ever any doubt about where the tip is, an X-ray is a really simple test, and it's really the only thing you can do short of someone who's very skilled with ultrasound to just be able to quickly confirm the tip position. And it's a kind of common and ready method of imaging. So I would say if there's any doubt, yes, always do the chest X-ray. But if you've got someone like you described who's just had their PICC line put in, and we've got the printed strip in their notes, and you can see the intracavitary ECG, and we've said that it's fine, then that's also fine.
Another common call, PICC lines come out 5-10 centimetres. So to me, then that PICC line in my head is a midline.
Yeah, that's a yeah. Go on.
Yeah, I mean, what should we do? Should we keep it as a midline? Do we pull it out, put another PICC in? Obviously, it could depend what's going through. If we have an agent that's not going to cause thrombophlebitis, should we keep that line in? I mean, that's a bit of a challenging call sometimes.
Yeah, and I think so. There's a couple of things to say. The first thing is most systems will have in place some parameters around, do a chest X-ray if the line's migrated more than 2 centimetres. Most of the time, that's going to just be because you probably won't really be in the ideal position. So firstly, I would normally tell people, and Liana and I've had plenty of these conversations, if it's moved 1 or 2 centimetres, then generally speaking, we're not sort of too worried. But definitely if it's come 5 or 10 centimetres out, I think it always warrants confirming the position. And I think that also part of the challenge is that irrespective of the type of agent that you're putting in, we know that the risk of thrombus increases the more or the less central that the tip becomes. So I think if this is someone who's a week away from finishing their therapy and they're on something that is peripherally compatible, you'd be much more inclined to just leave that alone, tell people that it's not a central line by all means, but put in whatever the controls are for that patient so that they continue to just get a pragmatic solution to their therapy. But where this has happened on day 2 at the beginning of a 6-week course, it probably warrants a phone call with somebody to just consider whether or not the device needs to be replaced. I think there's a lot of really old data, but it's still interesting and I think to some extent, instructive from the US that looked at, the risk of thrombosis at the cavoatrial, even in the superior right atrium, which is, a place I'll commonly put the tip. So superior right atrium is also a sort of reasonable spot to put it. And, it was sort of like whether it was 2%, 3%, 40% basically into the brachiocephalic vein. So the more peripheral your tip becomes, the much greater the risk is. And of course, in sitting in the brachiocephalic vein or in the subclavian vein, you're then dealing with a central venous thrombosis, and the management considerations for that patient tend to be 3 months of full anticoagulation, and that may be a challenge for your patient, especially given the frailty of some of the patients on HITH services. So I think it's always got to be balanced with the person who's actually there, but as long as the tip is well positioned and then there's a kind of pragmatic judgment made around, what the ongoing use will be, then you can often kind of navigate those things pretty easily, I think.
And so I guess just further in the interest of time, moving on to tunneled lines, we've got a little model here. And we were talking earlier that not everyone has access to power lines. So if you could sort of just very briefly talk about our tunneled options, why you would go tunneled over PICC.
Yep. So we might be a little bit unique in our service in that we have access to a product which is essentially a PICC line that has a cuff on it. So if you think about it in the sense that it is a small caliber line, and you might even want to just show, so in the same way that PICC lines are sort of 4 French, 5 French and 6 French for single, double and triple lumens respectively, this is exactly the same type of line, but it has a cuff on it and it's tunneled under the skin. So we tend to use these for people who we know need longer than sort of 4 to 6 weeks of therapy because we have access to them in our service. So the MAGIC guidelines are pretty clear about the fact that you could use either a PICC line or a tunneled line for patients who need somewhere between sort of 4 weeks and 3 months of therapy. So we have the benefit of being able to have access to this. And the reason that these are great is that they're a small caliber line and you kind of maintain a good catheter to vein ratio when you're using these. Whereas,
But they would have to be taken out in radiology.
yeah, so that's right. I was going to get to removal, but one of the big challenges with these is that because they've got a cuff on them, you need someone who can remove these for you that is accredited to do that. Now, in some services, if you have a local cancer service or something like that, you may find that there's a CNC or a doctor who can just take them out. They're usually pretty easy. Most of the time, they just need a firm tug and they'll come out. But sometimes they do need a bit of blunt dissection, especially if they've been in for longer than a few months. Whereas a Hickman's line, so this is the power line, a Hickman's line, which is, I think, what people are more used to thinking about when they think about a tunneled and cuffed central venous catheter, is generally a much bigger caliber line. So this is a single lumen Hickman's, and it is about 10 or 11 French, whereas this double lumen power line is 5 French. So you don't get the same catheter to vein ratio, but a Hickman's line generally is the sort of line that we'll refer people for if they need home TPN or they have a really long-term requirement for a tunneled vascular access device, because they don't block as easily and they're a little bit more durable. And especially for people who are self-administering home parenteral therapies, there's usually the ability to have a lot more line kind of external so that they can actually pick it up and change infusions and things in front of them, whereas the power line tends to sit really just over the pec muscle and on that sort of, sort of anterior chest wall in a way that makes it a bit harder for people to be able to do it. So you think more of the, even though this is technically a chronic catheter, you kind of think this is more the acute long-term therapy as opposed to the really chronic long-term home-based therapies. The main reason that these are recommended at all over a PICC line is that the thinking is that with the cuff and the subcutaneous tunnel under the skin, they're less likely to get an infection that originates from the insertion site into the bloodstream because there is a much greater distance and a barrier with the tissue ingrowth cuff. I'm not sure that the evidence around that has ever really definitively shown that one is superior to the other, especially given that we know that there are definitely patients that have PICC lines for a really long time. So our message to people would be not that if you don't have tunnel and cuff lines in your service that you need to run out and get them. It would just be that PICC lines are certainly suitable for really extended durations of therapy, as long as your system is sort of well equipped to look after them, and that some of the drawbacks for a tunneled and cuffed line is usually around removal. So we won't do that for people who go out to a really regional setting where they're not really used to cuffed lines. Instead, we'll just do a PICC line because people are much more familiar with them.
Perfect. And I guess the last sort of device, we're sort of running out of time, but we've got the ports. So we've only got 10 minutes left. So ports, should we talk about them briefly? I mean, accessing ports, that's a whole talk in itself, really.
We could just talk about the use.
A lot of our patients have ports. If they've got a port, should we be using that instead of inserting another line?
And I think this is one of the things that comes up a lot, right? So if the person has a port that isn't otherwise being used, that's a great reason to use a portacath for your therapy. Sometimes when people are actively having, it's usually cancer treatment. For solid organ cancer is kind of the typical reason that you get a port inserted. So people with hematological malignancies and things don't tend to get these because they usually need multi-lumen support. But solid organ tumours that have had their surgical intervention or that have at least had their workup tend to get a port inserted. And if they're actively having that used for chemotherapy, sometimes the oncologist might be a little bit more reluctant for you to use it because obviously if it gets blocked, it's a bit more of a problem. But I think the interesting case is your patients who have repeated admissions for parenteral therapy because they're becoming end-stage COPD, lots of infective exacerbations, and we've certainly had a handful of these patients that we've referred for a port. Also patients with cystic fibrosis who basically anyone who has a chronic condition that predisposes them to regularly requiring parenteral therapy. There's not a great trigger for those people where we know at the outset you're going to need 3 months or more, we would generally say you should get a portacath.
Yeah.
But for patients who you are seeing a lot on your service, part of the challenge is that you will eventually get venous depletion in their cannulatable or accessible veins in the upper limbs. And so you have to make a decision before that happens to give them some reliable IV access. And a port is a really good way of being able to do that, so that you've got somewhere for staff to be able to access, and it just simplifies their management if that's something that you can see is going to be a regular requirement for them. And so I think that's a case by case consideration, but it's definitely worth making the referral if you think that that's part of it, and talking obviously to their treating sort of specialist about what they think the prognosis and trajectory is, because it makes people's life a lot easier, and they don't even have to come into clinic. Often you can see them on home visit or whatever and start things.
Okay. And Liana, do you want to? We've got 2 minutes. Do you want to talk about now?
So just really quickly, 2 devices that we use in hospital in the home. This one here is a vein finder. This is used by all of our some of our staff that go out on the road. This device, it does have limitations in that it does pick up a lot of superficial veins, so it can be quite useful for the staff. And I don't know if you can see there, it's just showing up the veins in Elliot's forearm here. So it can be quite helpful for staff just locating superficial veins and getting access for our normal cannulations. It is in your patients that have got difficult access, it is not helpful, but our staff have said they've found it quite useful, and it does give them just a bit of reassurance when they're out on the road. When we were talking about moving to ultrasound guided cannulation, this is now our ultrasound probe that we can take out into the community. We're just awaiting our tablets that these connect to, but you can actually use them on your mobile phone devices. I haven't registered this one, but you'd have your ultrasound here. So we'd set this up out in the community with the same prep that I would do in the clinic. We use a big machine in the clinic here, but we can take this out obviously into the community and be able to cannulate our elderly patients or our immobile patients that aren't able to come into our clinic. So that's becoming really useful and a tool that we're going to roll out across the service.
And the biggest thing to be aware of is that these things are great for superficial veins, as you said, but basically anyone who's got difficult IV access generally has no superficial palpable veins, or even no superficial non-palpable veins. And so thinking about getting ultrasound as part of your arsenal will help to make you a bit more self-sufficient.
Yeah, exactly.
Shall we open it up to questions, Heather? Have you got any questions? No. Does anyone have any questions? If you want to put them in the chat now, that would be fantastic.
Stunned silence. That's the way we like it.
Lots of great sessions.
This is a big topic, and we've kind of skimmed the surface, haven't we? I think one of the things, if I could leave people with like a kind of parting message, is that there's so much that HITH services can start to do themselves with the support of, whoever your clinicians are that do vascular access in your hospital. But that actually beyond the procedural elements, a lot of it is about understanding what goes into the decision making around certain lines. And so many services already have a pretty good understanding about this. But I think being an active part of that discussion and partnering with whoever is doing the insertions will just make sure that you're doing the best thing that you can for the patients that are in your service. And given that the philosophy is how do we manage people in their home, in their space, and, that's part of it, I think any amount of investment in relationships and that, you can kind of do with your local services is only going to be fruitful, right?
And I think any way that we can prevent patients even having to come to clinic, and that's utilising this new tech. We've got this big ultrasound machine here. If I put it in front of me, we've got a huge machine, but we've also now got these small machines. And if we can use the tech to keep people at home and upskill staff, we have we've got quite a few nurses that can do peripheral ultrasound.
3 fully trained staff in our service now, with the plan to roll out some more training over the next coming months.
Some questions.
Someone's just asked, so is there a different protocol for PAL-PICs, such as syringe sizes to access?
So look, I think generally speaking, the answer to that is that we tend to tell people 10 ml syringes because they generate, a safe amount of pressure. what I can tell you definitely is that someone who handles PICC lines all day, if someone calls me and says that they've got a blocked PICC line, the first thing I do is get a 3 ml syringe. The pressure injectable lines definitely help to reduce the risk of line rupture. Anytime though, I've ruptured lines before, so it's a real thing that happens, and it's a pain because then you've got to change the line. Generally, there's no harm that comes to the patient, but it's just annoying. And so I think generally speaking, the right advice is 10 ml syringe is good, and then call your experts or call whoever you call when you've got a vascular access problem if needed. But yeah, you know, with a bit of gentle kind of pressure, you can use a smaller syringe and often mechanically unblock something just as a temporary thing.
Someone's just asked, is there any way to know, I'm guessing they mean externally, is if the PICC line is cuffed or not just by looking at the line?
So you kind of need to just be familiar with them. Most of what I'm, the big thing is that it's very uncommon. In fact, I'm not aware of any services that put cuff lines in patients' arms. So part of the challenge is that I'd make everything look exactly the same. So this here, which you can see is a purple line, is a cuffed line, and you can see this cuff maybe here, this white bit, that'll be under the skin and difficult to find. And this is a PICC line, and they're almost indecipherable, other than one of them says power PICC and the other says power line. So the things that tell you this line could be cuffed is that it's in the chest, it's coming over the top of the clavicle. So these are put in the internal jugular vein, tunneled under the chest, and then put into the RJ over the sheath that they've put in. So you can usually feel it going over the top of the clavicle. That's your first clue. And then the second clue is just that it's in the chest wall. So if it's in the arm, it's almost certainly a PICC line. If you're ever unsure, just ask the people who put it in. If you can't and it's in the arm, chances are it's a PICC line and you should just be able to pull it out.
Oh, Jeanette said CVC, not PICC.
Yeah.
Oh, you can say that.
Yeah.
Excellent.
What was oh yeah, right, okay.
And just if there's time to talk about taking drug levels from PICC lines, which is a topic that actually hot topic in our service.
I'll defer to you then.
We have been doing a lot of research over the last couple of months because we've got a few patients on amikacin that we're doing levels on. And we have found that if you do in fact take a good level of discard blood from your lines, you can take drug levels, and they seem to be pretty consistent with peripheral levels. We don't have the hard data on that yet. We probably need to collect some more of that and see, but it is something that we're monitoring because we do obviously have patients with difficult access that we're not able to get peripheral levels on. And also, if you've got the option of having dual lumens, utilising the other lumen that you're not putting your drug, the one that you're doing drug levels on, taking it out of that lumen can help as well. Anyone?
No, my feeling on this is that you should, you know, aspirate, discard, take the level. If the level seems strangely elevated, then you should do the test again.
Exactly.
But yeah, that's my.
I think we'll have to wrap it up, but people are welcome, I guess, if we put in the chat details of myself, Liana, Alex, and Elliot, if anyone wants to reach out with further questions. I think there are a couple of others, but I think we probably need to wrap it up. And I'll just put a quick poll to see if it was useful and to see if anyone has any other suggestions for webinar topics going forward, if anyone has those. But Alex,
thanks,
wrap it up.
Yeah, no, thanks everyone for joining today. I hope it was useful. I think these education webinars are fantastic, and you know, if there are any ideas that people would like more information on or more education around, you know, the aim is to make this a regular thing from the Hospital and Home Society, and make sure that everyone comes to the conference in Sydney in November this year. We'll definitely try and get some presentations from our Vascular Access Society colleagues. And thanks for joining. Thanks again.
Thanks, Ferris.